So our first presenter is Dr. David Magnus, who is the director of the Stanford Center for Bioethics, and he will talk to us about the ethical challenges in the learning of the learning healthcare system. So welcome, Dr. Magnus. Thank you.
And sorry that I forgot to change the title, but thanks very much. Thanks for having me. I don't have a disclosure slide, but I have no financial conflicts of interest. Conflicts of commitment, I'm vice chair of the IRB for the Precision Medicine Initiative. All of us research program. I'm a member of Stanford's IRB and Data Use Policy Committee. And I guess potentially for conflicts of commitment, I'm on the ethical and regulatory affairs working group for the NIH Collaboratory. So that's it for potential conflicts of commitment. Just in time. So, okay. So what I'm talking about today is really about the sort of intersection of all these confluence of all these big things, right? Big data from huge sources, genomics, electronic health records. We're sort of seeing all this data, and the idea that we can provide precision health, precision medicine to do things for people are all intertwined and becoming increasingly intertwined with the notions of the learning health system. And a lot of that really depends on predictive analytics and developments in artificial intelligence. So, so again, lots of information, genomics. It makes quality improvement, ongoing learning possible in a way that wasn't. And the learning in this learning system, as we heard this morning, is really learning being done mostly by algorithms. So it's algorithms that are doing a lot of the actual learning in the learning health system increasingly. And I would say there's a growing perspective that a lot of the learning in the learning health system is going to be done by big data plus AI, and that's very attractive, and the idea that this would happen to reduce our reliance on randomized clinical trials is attractive because randomized clinical trials are so incredibly expensive, time-consuming, and hard to do, partly because of regulatory requirements. So why is everyone excited about all of this? And mostly it has to do with limitations of current clinical practice, right? So physicians are always limited in the number of variables that they can take into account when they're making decisions, even when they use very crude algorithms. If you think about things like SOFA scores or Apache scores to make predictions about mortality for making judgments, it's still a fairly small number of variables that can be taken into account. Moreover, data is limited to sporadic encounters. It's a snapshot rather than continuous stream of data, so depending on exactly when they came in to see their physicians or when they happen to be evaluated. And then there's a lot of bias in physician practice, and that happens at a lot of levels, including the fact, whatever happened with the last patient is likely to have a disproportionate influence on what happens to the next patient. So for all those reasons, people are looking to the solution in large amounts of data, omics data, electronic health record data, wearables, mobile health applications that can potentially give streaming so you don't have to just have snapshots anymore, combined with using different algorithms to analyze this. Just to give some, we all heard lots of great examples of that earlier today, but some other examples. Patient presents for palliative radiation. Right now, physicians sort of crudely bin them in their heads between those who have less than 3 months to live, those who have 3 to 6 months to live, and 6 months to 2 years. And the reason why they do that is the ones who they think have a very short period of time to live, they're going to send off to palliative care. Those who they think with aggressive treatment might live for a couple of years, they give very aggressive radiation, and those who are sort of in between, they give sort of lower levels of radiation. Physician prognostication is not very good at knowing where people go in bins, so some colleagues did surveys for predictions, and it's not very accurate. So physicians aren't very good at knowing which bin people should belong to. And there's the potential that machine learning on data can be do better, possibly much better. In fact, my colleagues have developed something that didn't even require deep learning, just lots of regression with lots and lots, thousands of variables, able to be much, much more accurate at predicting who belongs in which bin. And so we could get similar guidance on decision making, who should be prioritized for organ transplant, which patients should be sent to the ICU, which we heard a little bit about earlier today. These are all things that might make us be capable of being better predictors of getting care that's really more appropriate for patients than right now on the basis of just individual physician experience rather than having all this information. But I want to talk about some challenges and problems that exist with this approach, some challenges with machine learning and its application in healthcare. And when I talk about some of the biases and problems that arise, I'm going to try and argue for why it's really important to maintain the value of randomized clinical trials and why that's going to still be important, as well as the need to rethink some other issues in our general ethics and the way we approach this. So 4 major challenges that I want to talk about, and besides privacy, security, which a lot of people talk about, issues around control and access to the data used by third-party vendors. I'm not going to talk about any of that stuff, and I'm mostly not going to talk about consent. That's going to be a topic that other people are going to talk about. So I'm going to talk about 4 issues. First, the way in which different kinds of values and interests get embedded in the algorithm design process. Second, some of the biases and limitations in the data that it learns from. Third, issues around misuse or inappropriate use or not using things well, or the way they do or do the results of using machine learning get used. And then lastly, the significance for the ethos of medicine. So let me start with issues around values and algorithm design. So there's actually, it sometimes seems like that should be a completely neutral activity, but actually there are value-based decisions and interests that wind up getting embedded in the design of the algorithms themselves. What gets optimized? How do you weigh variables? Those are all decisions that have to be made, and those are value-laden decisions. So for example, third-party vendors selling algorithms to healthcare systems could very well value different outcomes than patients or their physicians. Like if I wanted an algorithm to predict who's going to do well going to the ICU, and somebody's trying to sell that to our healthcare system, they might care about the insurance status or ability to pay and say, we'll be just a little bit more forgiving in the way we design our algorithm because we'll consider that to be one of the outcomes, could be financial implications. Or maybe even more realistic, because we're already seeing this a little bit, the tyranny of quality metrics. Our institution seems to be obsessed with CAUTI and CLABSI rates, which I'm sure everybody is, but we tend to really focus on all of these discrete measures that matter for our CMS reimbursement rates. But again, you can imagine designing algorithms that will maximize those outcomes because they matter so much institutionally, but that may not correspond to the interests of patients or interests of physicians who take care of them. They may not actually be completely concordant. On its surface, it might sound like having higher quality is better, but there actually can be ways in which that actually can lead to a conflict. Okay, there's also biases and limitations in the data that the algorithms learn from, and algorithms are only as good as the data that they learn from. And I'm going to talk about 3 different challenges. One, the fact that there's data missing, which makes it really hard in systematic ways from some populations. Second, that there can be a bias in the data leading to self-fulfilling prophecies, and I think that's a problem. And then the third, ways in which accurate differences in health outcome can be a function of social justice and social injustice and the dilemma that I think that creates. So first, there's population bias in the data that's available. This slide, which I don't know if people can even see this, but while there was some improvement between 2009 and 2016, mostly in Asian populations that were taking place in Asia, if you looked at international studies of genome-wide association studies, 81% European ancestry, the percentage of people of Hispanic or Latino, Latinx descent was like less than 0.5%. So if you look at clinical trial data, if you look at genomics data, if you look at all these studies, underrepresented groups, minorities, are not included in those databases. If they're not included in the data, they're not going to be available. The same happens clinically. How frequently you go to the physician is going to influence the quality of the data. If certain populations systematically don't go to physicians as often, that's going to make a difference for that. So there's just, the data is just not there and not representative of certain populations. Second, there can be self-fulfilling prophecies as a result of biases in decisions in the data themselves. And I'm just going to use an example from a study that we published about a decade ago. We did a survey of listing decisions for organ transplant for solid organs for kids who had developmental delay. And if you looked at developmental status, I don't think this is necessarily the most interesting finding, but it's the one that's gotten the most press. 44% of programs always or usually take neurodevelopmental delay into account, while 39% rarely or never take it into account. If you look at which programs consider neurodevelopmental delay by itself to be an absolute contraindication to listing, again, you see the same kind of variation, with 40% saying they never would use it and 44% saying that could be an absolute contraindication with different cutoffs. Well, what does that mean? Well, that means if you make the decision that based on developmental delay, you're not going to list somebody for transplant, then guess what? All those kids die. And if you're in a program that makes that decision, your algorithm that looks at outcomes is going to see that being developmentally delayed is associated with really poor outcomes. And this applies to transplant, but it's actually quite systematic, right? So you see that surveys have shown the same thing for access to ECMO, surgeries for hypoplastic left heart. So if you're a child with developmental delay and we systematically don't do things that will be life-saving for you, you will have very poor outcomes, and our algorithms will learn that kids with developmental delay usually do really poorly and usually die, and this has a potential to reinforce and reify the existing biases that are already there and reflected in the data in the electronic health records. Then the last one is that's really about a bias in the decision, and the reason why I say it's bias, I didn't include this, but the data suggests that the kids do just as well who are developmentally delayed in terms of outcomes. But there can be actually accurate differences in outcomes that are also biased because they reflect issues of social justice. It's well known that there are real differences in health outcomes that correlate with the social determinants of health. So the health-wealth gradient. If you want to know one of the most powerful predictors of lifespan and health in our country, it's zip code, right? That's a very powerful predictor. So we already know there's a very powerful health-wealth gradient. We know that there exists, even if you fix for for wealth, there's also racial and ethnic disparities that exist in our populations. So we know systematically that people from certain groups, as well, certain minority groups, racial and ethnic minority groups, as well as people who are poor, are not as healthy and don't do as well. So since both race and socioeconomic status are associated with significant levels of what population health people call excess death in those populations, all of that information is going to be captured in our electronic health records. So social injustice broadly in our society is actually embedded in our actual outcomes data that our machine learning is going to learn from. And what it's going to learn then is that those traits predict worse outcomes for those groups. So when I gave the examples earlier, when we're deciding who should get organs, who should go to the ICU, who goes in that bin of 3 months to live, 3 to 6 months, or 6 months to 12 months, given those social injustices, people who are minorities, people who are poor, are more likely to be binned into the categories of not doing as well. And again, this will reinforce and reify existing inequalities and health disparities. There is an alternative, right? And this is where it really comes down to the fact that the design of algorithms actually are value-based decisions. We could make our algorithms so that they are blind to some of those factors or will not take those into account. Or we can find ways of boosting up points in different ways for those populations as a response to existing social inequality. But to the extent that we do that, it means those outcomes won't be as good or as predictive in terms of just strict mortality or morbidity or other kinds of outcome variables that are often utilized, which creates, I think, a real dilemma for designers. But again, these are value-based choices that are going to be made that are going to be very important for whether we're going to reinforce existing injustice or mitigate it. The third thing is I'm calling misuse of the algorithm. That may not quite capture it correct. Clinicians in health systems are probably not aware of all the data limitations that exist. In fact, I think that's highly likely. One of the challenging things about this era is that first, it's hard to, even if you know something about algorithms and look at it, the whole point is that these things are learning on their own, so some of the operations of these algorithms are opaque, even to individuals who are fairly sophisticated. But of course, it's even more problematic because the clinicians who are end users of these things are usually not very familiar with these kinds of predictive analytics. So it's a complete mystery. It's almost a complete black box, which is really problematic. It can also be made even more challenging when it's developed by potentially third parties and as proprietary. Physicians in health systems, as a result of that, may not be aware of the value decisions that are embedded in algorithms, and algorithm results may be applied to individuals in populations where it's not as predictive, and it may also be used in ways where we don't really know exactly what the outcomes are. This is not exactly on point, it's not exactly an application of this, but it's a great illustration how the assumption that more knowledge about something automatically leads to something better, and this is an example I actually got from Ben Wilfond, when in the early days of cystic fibrosis screening, I mean, it's obvious that cystic fibrosis screening is a good thing and giving people information. It's better to identify at birth rather than wait until they're a little bit older and get identified. Only one state said, well, let's find out if that's really true, and did a randomized trial. And sure enough, they found out that they had worse mortality in the populations where that information was being given to them as a result of parents taking their kids in and cross-infection. So the point of this is that how it actually gets utilized in practice is sort of an open question, and we often may not know exactly how this information is being used. So for example, if it's just being handed to people, what if physicians differentially use it in ways that are unintended, or ways that are, if it's just information, we don't really know what people are going to do with it when it's being handed off. And so a lot of the examples earlier today where people are handing it off, that's why it's really, really important for us to learn about what people are doing with that information, and it's hard to really understand that if all you're doing is looking at it observationally. What are some possible solutions to some of these problems? Well, obviously we need transparency. We need more transparency in the algorithm design process. We should be cautious about allowing third parties to develop proprietary algorithms. There's a need for clinicians and end users generally to understand how algorithms work. I think 10 years from now, computer science will be a major, and computer engineering is going to be a major part of medical education. I think it's inevitable that has to be the case. There's also a need for close collaboration between clinicians and engineers as design takes place, and that may sound obvious, but it's shocking how infrequently it happens. I was at a National Academy of Medicine workshop that I helped organize about the use of some of these computational methods in precision oncology, and some of the computer science folks and engineers who design these systems basically say the problem is we want to know what outcomes we should be paying attention to, and what variables really matter, and so we bring in a handful of physicians to help us, and they don't agree with each other, and they tell us different things, so we decided it's easier to just forget the physicians and just sort of figure it out ourselves. So a lot of the things and a lot of the designs of these systems are actually being made by computer scientists and engineers who don't know anything about medicine, with actually shockingly little input from physicians in the practice. There are exceptions to that, and there are times where it's happening, but I'm amazed at how often that's really taking place. There's a need for the recognition that there are values and interests in algorithm design, and a need to reduce disparities in the data. One key take-home point from all of this is that at the end of the day, no matter how big the data and how powerful the machine learning tools we've got, at the end of the day, all these are really, really powerful observational studies with all the limitations and problems and challenges that observational studies have. And so again, that speaks to why I think it's really important to recognize that there's still a need for randomized clinical trials. If they hadn't done the randomized clinical trial and found the differences in the mortality rates, they wouldn't have known to be more careful about cross-infection for younger kids. There was a lot to be learned from that, and there's a lot that we can learn by trials that you're not going to get from even the most powerful randomized studies. Alex London, who's written some stuff about this, who's a philosopher who writes about AI, has a great example from the Pittsburgh program. They were interested in understanding which patients are at greatest risk of needing hospitalization, ICU care, and mortality from influenza, and they found when they run it through their data that, surprise, surprise, patients with asthma do better than patients without asthma. Say it again, patients with asthma do better than patients without asthma. So again, does that really mean that, gosh, if we really want to do well with flu, we should probably find a way to inculcate asthma in our patients? No, it does not mean we want to do that. What it highlights, again, is maybe there's an opportunity to learn because we know it's kind of crazy. At Pittsburgh, they took it as an opportunity to just tweak their algorithms in different ways. But in the end, all the algorithms do is capture whatever is existing in your system and the data that you've got. And what we need to do is to move to beyond that, is to have find a way to have actual randomized pragmatic clinical trials in order to do that. But the problem with doing that is that one of the reasons, again, that motivates the whole search for an alternative is that the cost and burden on clinicians and on investigators is so high for doing randomized trials. And so I want to just give a brief summary of this article that a colleague of mine wrote about integrating randomized comparative effectiveness within patient care and finding ways of doing it. And just this highlights some of the challenges that our regulatory system creates. Right? So sometimes these things are conceptualized, and we saw a little discussion about this morning. Sometimes these things are conceptualized as quality improvement projects and hence largely outside of our regulatory system. Sometimes, in contrast, they might be pragmatic trials that are integrated into the system, or sometimes they're somewhat separated from being a pragmatic trial. So they describe a few examples, and I'm just going to briefly talk about the two of them, the chlorhexidine bathing trial and the RetroPro and ELUNG trials that were linked in the UK. So these are all randomized trials that were conducted. But in the first one, the chlorhexidine bathing trial, though it was a cluster randomized trial in which a number of ICU units were randomized and then it had a crossover effect, the comparison of daily bathing of chlorhexidine with daily bathing with non-antimicrobial cloths, the IRB found that to be an example of QI and hence exempt, and no informed consent was obtained. So it was fairly easy and straightforward. In contrast, the RetroPro UK trial that compared statins and the ELUNG UK trial comparing immediate prophylactic uses of antibiotics versus later use for acute exacerbations of COPD, the total approval process from the federal system took 2 years. And we heard earlier today some discussions about FDA regulation in this area. That should not be surprising. If you decide you want to really do this and go through the FDA process, we don't really know exactly how long or how fast that process is going to be. It resulted in lengthened informed consent forms, which are harder for people to understand. It also created a burden on physicians who agreed to participate, because there's a real decision about who does the recruiting. If you have the physicians themselves doing the informed consent process, it may make them researchers under the regulations, and then now they're having to do all this other stuff that could make things much more complicated for them. As a result of all those different burdens, it not only delayed things for a long time, but in the end, when they had 459 practices, clinician practices in the UK that they reached out to, and 270 expressed interest, only 50 completed the site submission, 35 completed all the mandatory training, and 17 recruited patients. 3.7%, and a similar for the ELUNG, only 1.3% of the 459 practices wound up participating. So you can see an incredible, okay, almost done. So you can see that our current regulatory system creates real burdens. So I'm just going to wrap up. My last problem, the fourth problem that I wanted to talk about is the implications of AI for the ethos of medicine. In a way, our whole ethics system, I think our regulatory system and our clinical ethics is built on an ethos that goes from Hippocrates to Ed Pellegrino and David Tomasma of really seeing the physician-patient encounter as central to our whole ethos. And our research regulations, in a way, embody that too in a lot of different ways. It's sort of parasitic on it, and it builds on the fundamental nature of this dyadic relationship. The reality is that relationships between patients are really often with a healthcare team and a healthcare system, and now it's going to be with an algorithm or a set of algorithms. Patients do want to know when their physician's autonomy is limited, even if it produces better outcomes. And there's some data, Scott Halpern's got some data showing that. So patients really do want to know this. And there's a million ways in which physician autonomy is being constrained in all this. So the real question is, if it's really about a relation between a patient and a healthcare system, how do we reframe our notions of relationship and obligation in a setting where it's a relationship with a community of patients and providers and analytic tools that help us learn as we go? If we're going to be part of this, how do we do this? And so to me, the learning health system is not just an opportunity for us to learn, it's an opportunity for us to, at a fundamental level, rethink the entire ethos of medicine and the way we think about it. And in a way, the work that Nancy Cass and Ruth Faden and others did when they published back in the Hastings Center, all the work that we did on ROMP, all the work that a lot of others have started to do, I think is just the beginning of the process of starting to try and rethink through what a new ethos might look like. And when we can really think about that, both in the clinical ethics setting, hopefully we can figure out a way for the regulatory system then to catch up to this new way of thinking about ethics. Thank you very much.
So our next presenter this afternoon is Dr. Glenn Martin, who's Senior Associate Dean for Human Subjects Research here at Mount Sinai. He will speak to us on ethical review challenges for IRBs.
Good afternoon. Pleasure to be here, and I think if Andrew, this would definitely be the first ethics meeting I've ever spoken at, so thank you. Well, you'll see if it was a good idea or not in a minute, but thank you for inviting me. Usual disclosures, so nothing, I don't have anything really to disclose. My thoughts and opinion are mine, though I may deny it, and certainly have nothing to do with my employer. And the other disclosure is everyone hates the IRB. And I actually do have evidence. This, my department gave this to us because the American Psychiatric is coming, said this is their suspected slide. You'll notice Mount Sinai in the front and center. Nowhere in there do you see the IRB. Because the IRB is somewhere about, I don't know, 60 yards to the left on First Avenue. So we are safely away from the faculty and the dean, but still do our best to provide the services. So with all due respect to Tina Turner, what's ethics got to do with it? Because I'm a regulatory guy. Now, the regulations are theoretically based on ethical principles, and one would argue they are, but when it comes down to it, I got to enforce regs, and I have to try to make sure that we allow the investigators to do good quality research and protect patients and subjects at the same time. Yeah, patients and subjects is another interesting conversation of what we're supposed to call people and the like, but that's not to worry you. In fact, if you go through the entire 45 CFR 46, which is the common rule, ethics is mentioned all of 3 times. And it only has to do with either basically an agency head, if he says he doesn't want to follow the policy, he's got to follow the ethical principles of the Belmont report. And then it's mentioned a couple of times for the research it isn't approvable for children where there's no direct benefit, no high risk, and then with pregnant women, fetuses, and neonates. You have to go to HHS and ask the secretary for help, and then they supposed to use ethical guidelines. And then one of the key things, and this will come out and why it can be frustrating, both for our stakeholders and customers, is the answer to all questions posed to an IRB. I know there are IRB members who know the answer, but if not, for the rest of you, it depends. There is no situation where we generally can give you a clear answer for almost anything. But I would suggest, so either you're going to yell and scream that it's, problematic variation between IRBs, they don't know what they're doing, they're not trained, they're not this, they're not that. I would suggest it's almost a logical outcome of chaos, and I'm speaking chaos from a sort of mathematical situation. I would disagree with Andrew because I don't think, he mentioned earlier about all these things helping him predict the snow. As far as I know, we still can't do it after about 3 days, 4 days out with as much precision because the chaos of the mathematics makes it essentially impossible to do because of the exquisite sensitivity to initial conditions and the like. The initial conditions, I would argue here, is the protocol. What is the darn study you want to do? They're never the same, and there are always things that separate them. So the study variables are the sort of things, and this is why it, occasionally for somebody who's not an ethicist and read some of the literature where it gets a little bit maddening, but it's the same, I'm sure, when you read medical literature, is what people sort of assume are trials that have trivial things or used as example are not necessarily trivial. So the simple thing is the timing of medication. Oh, why would you need informed consent if you're giving something, twice a day as compared to once a day? And the question is, well, if the once a day is in the morning and it makes you sedated and you're driving to work, that's probably something that may increase your risk, or at least is something that has to be considered. It's not a no-brainer that it's going to be good for you. Age of participants, obviously, everyone puts down 18 to 65. I don't know what happens magically at 65. I'm getting pretty damn close, and I hope nothing astonishing happens. Or why 18? Again, reminding people of the obvious, which is we make a lot of arbitrary decisions that are based on absolutely nothing other than we do it. And then the location and context of research, if you're doing it at this medical center as compared to some of the more peripheral hospitals or a real, perfectly wonderful, solid community hospital that still exist. less and less. And then, oh yeah, and then there's I'll come back to it, but it's a general fallacy in my mind is that people think we need to get, everybody's got to participate or it's not valid. That sort of feeling that you get when people ask for waivers of informed consent because people will say no, and if too many people say no and we're underrepresented, et cetera, we can't have good science, we're not going to come to a conclusion, to which is potentially valid, but is frequently just tough. I mean, life is filled with that. You know, it's the sort of thing that people will come to me and complain about that, but they won't complain about the data they're looking at is garbage, and they have to clean it out, and it's really who participates or not is not their real fundamental problem. It's they have all sorts of other design limitations, and it's nice to pick on this one. And then I would call the regulatory mush that we're supposed to work with, and everyone in this room is probably aware of it. The definition of research is basically comes down to two words, systematic and generalizable, neither of which are defined, and neither of which make a great deal of sense. So by systematic, does that mean if your research is so poorly designed that I won't even call it systematic, it doesn't require approval and we should do it? Well, because I understood it, there is no definition for QA anywhere in the regs. So if you decide, as you said earlier, the IRB said it was QA, and therefore they didn't care, that's usually predicated on either it's not a study at all, it wasn't designed to do anything that you could possibly conclude, but they want to roll it out, or they were told, here are the 5 things we need to check for whatever reason, they follow it, it's not systematic, you leave it alone, or they'll argue what we're trying to do is only good at Mount Sinai, and we're only trying to do things and it's not going to be elsewhere. And I remind people that's wonderful, but if you do cure cancer or stop people from falling and breaking their hips and it actually works, you may want to share that with people. And the fact that you went in as a QA doesn't mean you can't generalize it or just come back to an IRB and ask for secondary use of the data or whatever. But it does allow for a huge degree of variation because frankly, when you said that first project was considered QA, and it was, that's not how it struck me. But again, I don't know any of the details and that's the problem. Minimal risk, well, you all know the difficulty of defining what minimal risk is, even what's ordinarily encountered in life. When I first was getting into this business, and you've been in it long enough, certainly in the 80s, while the crack distribution network in New York City was being dealt with by, unfortunately, drive-by shootings, if you lived in the projects, your life expectancy was a hell of a lot lower than my kids were growing up in Forest Hills. That doesn't mean, no, so does that mean that they, the residents up the block, ordinarily put up with a lot more nonsense that my kids did growing up, certainly in terms of violence and the like? Does that mean I can do more risky studies with them? Logically, you could argue you should. Ethically, it sounds absurd, and I know basically everyone has come down on agreeing that, but it gives you the amount of discussion about what is minimal risk and where does it really kick in and at what level. The algorithms, as were described, they don't have to be minimal risk at all, depending on who's doing it and what they're doing, and the fact that it's a closed box, it makes it very difficult. As checklists are usually thrown up as the example of an absolute minimal risk study, and who cares, but that is predicated on the idea that checklist works. As I said, after the second crash of the Boeings, the 2 pilots there might argue that the checklist they were given to turn off the software and take control of their airplane didn't work. It wasn't a particularly helpful thing at that moment. I mean, there are all sorts of things you can pick on in terms of Boeing in that. But again, a good checklist might be minimal risk, but it may not be. Who knows? The definition of practicability, I'll get to in a minute. The definition of identifiable, the identity of the subject may be readily be ascertained. For example, I think this is silly. I don't understand. Everything is identifiable. The only possible question is how much effort you want to put into it. At this point, we were saying that there's enough people in public genomic databases available that if you're European male, well, we have about 80% chance of identifying either a second-degree cousin or something right now, and yeah, and within 5 years, if people continue to do this, everyone will be identifiable more or less. And Andrew Kasarkis knows as much better than I do. If you were actually in a research study, and it's in one of those databases, it would take them about 15 minutes to figure out who you were. So everything's identifiable, and we should just get over it. I mean, we have to deal with that fact instead of arguing, oh, it's a not identifiable specimen. Oh, spare me. And then informed consent, it's like, yeah, we have the principles of informed consent, but then it just depends on what we consider informed. We're working on our version of the broad consent right now. We will not do the broad consent because of how it's written in the regulations, because we can't be responsible for tracking whoever says no, because that hasn't been defined clearly in guidance, and everyone is frightened to do that. And frankly, I don't really care, because we can write a consent that accomplishes what the broad consent wants to do. But I'm certainly not going to agree with the surgeons that will just throw it in with 100 other pieces of paper they get in, and they can sign it there with no ability to interact and the like. So by insisting that people actually, to what degree does somebody have to be informed? As you may have heard in the other extreme, that little EULA, the end user license agreement that you check to get free software or free Wi-Fi access or anything else. I know they had done this in London a few years ago, and at least 20 people gave away their firstborn child without any problem. They just checked the damn box for the free Wi-Fi, and in there it said they gave away their firstborn child. Which may or not have been a good thing, but that was not fully disclosed during the process. And they just did it again, and it was just as embarrassing. So, but it's important mush. It has consequences. You don't need, the details are unimportant. If you're in the IRB business, you've seen this before, but if not, this is the flow chart to determine whether or not you can waive informed consent. Because there's a lot of writing about, in this environment that we're trying to do, could we just waive informed consent? And then you can do tons of research and the like. The two keys that I'm just trying to point out is it only works for minimal risk studies, and that gets back to who's determining what the risk is and what do we consider as minimal, and then the practicality or practicability of it. And similarly, when it comes to waiving documentation, which can make life a lot easier also, still got to be minimal risk. So the definition of minimal risk, I don't have to read it to you. People generally know it. And then actually, they go on and do a better job almost of describing it, at least emphasizing there are the other intangibles, and not so intangible if it's your employability or bank account, that could also be at risk. And I would say this stuff gets a little bit on the non-fungible side. Once you've destroyed my reputation, I can't get it back, no matter how much money you do. If you harm me, you can usually pay me, but not this. This is like you don't put that genie back in the bottle. And what's practicable? So SACHARP, which is an advisory committee to HHS, said, you know, they're smart people thinking hard and doing a nice job, but they're not always listened to. They tried to define practicable, feasible, capable of being effected, practiced, or performed, all of which still allows you to argue all day about, well, how feasible is it? But they do point out something which I do admit IRBs lose track of, is that the emphasis on the impracticability to perform the research, not just the impracticability of getting consent. So we actually tend to jump all over the second piece and sort of forget the first hurdle is the first one, is the research of such that it has to, that in order to accomplish the goal of the research, you're going to have to waive informed consent basically to do it, as compared to whether or not you could get consent because it's 5,000 people or whatever it is. And that it shouldn't be just based on speed, money, et cetera. And they helpfully point out scientific and ethical concerns. The scientific would be the usual, that you're going to end up losing too many people. I don't know why they mentioned dead people, only because I don't care about dead people. You're not humans once you die under federal regs. It's no longer an IRB issue. It's got HIPAA implications because you die with your HIPAA rights intact. And I said, but everybody always will use that argument. The second one's a good argument, and it's one that most IRBs are aware of and do allow a certain degree, which is the with bias. Yeah, so basically, can you lie to people? Or withhold information or otherwise not give them complete informed consent. The thing that we do around here all the time, virtually without thinking about it, is various different neuropsych testing involving computers where a gambling task. And it works better if they believe they're playing against a real person. And of course, it's not a real person, it's a computer. So they will allow them to either not make it clear or even get a little bit more to the flat out misleading, as long as they meet the other criteria that it's minimal risk. They'll debrief people afterwards and the like. So this is something that most IRBs are used to dealing with if they have to. The ethical concerns, the first one's a little bit, yeah, I understand. I don't know if it ever comes up. And again, it's a little bit difficult for me to understand why contacting them would lead to harm, but I guess one could, you know, as I said, it depends. Somebody could come up with something. And the last one's a good one, which is basically, you know, can't you do it and get consent? You know, isn't there a group that you could actually consent that would be able to do it rather than the population that you selected that you said you can't possibly? Now, again, how practical it is in terms of getting to that point is another story, but at least consider it. So I do want to point out that this is now back in the 2010, a little bit after the concept of learning environments were mentioned, but it came out, and it was mentioned earlier by Matt, talking about anesthesia. So this was a double low study. What they wanted to do was, the anesthesiologists are sitting looking at tons of monitors, or one monitor with tons of lines. One of the things, not surprisingly, they're looking at is arterial blood pressure, important to know. And then there's the bispectral index, which is, I'm totally drawing a blank on, I thought it looked at oxygen saturation or circulatory something, and I apologize for not remembering it. And the question was, if you give an alert in the middle of the operation to the anesthesiologist, will it do anything? Will it have an impact in mortality? So basically all it was doing was looking at two lines or two data streams. When it hit the point, an alarm would go off, not a loud klaxon or anything. Basically a red light goes off and it simply says they've achieved double low or whatever it was. That was it. So it was initially, when we got it, we assigned it to the full board. One, because we weren't, internally, we weren't certain about the risk was, and also we couldn't quite figure out what expedited category we would slip it into. Because it wasn't exactly, it was a clinical trial, but it was a device, it was this, is that. So we felt comfortable sending it to the full board. Full board thought about it and deferred it, saying we didn't have enough information to determine risk. So we got an outside consultant in. Outside consultant, you know, wasted 2 weeks or so, but not much more than that. Outside consultant came in, gave us a good report. We resumed our deliberation. We decided it was minimal risk, both because we asked them if they misinterpreted it, if they overtreated, this and that, and we were convinced ourselves that it was going to be minimal risk. We made it expedited 9, which is what you do if it starts at a full board who goes, man, this is minimal risk. You can just make it expedited 9, so it stays that way going forward as an expedited review. But the board also said, now we need, you can do it, and we're not going to make you get formal consent, but we do want people to know what they're getting into, and we want people to be able to say, nah, I don't want to, for whatever reason. So, believe it or not, the PI agreed, and the study was approved. Interestingly, and this is sort of the counter-argument to not the counter-argument, but just where it was so hard to get practices in, and there were like 3% who had dropped that you managed to get. In this particular case, here was the deal. The patients were going to get it whether they came in through the pre-admission unit, through the medical clinic, or through the day of surgery admit unit. It was also on the website, which people were informed to go to about on your day of surgery, and there was a link there talking about it. They offered to put the letter in every surgeon's office, and it was written in English and Spanish. They educated all their physicians about it at a departmental educational conference, and then all the anesthesia team were given a script that they could look at to answer questions and the like, and they were made very clear, and they were also given instructions on how to withdraw somebody if they asked to be withdrawn. So they did training, they had a letter, we approved the letter, everything's nice. The anesthesia care team was basically told if the patient comes in, they tell them, and they don't complain or do anything, go and put them in the study. If they ask a question that you can't answer, go call somebody. And if there's any issue involved and the patient so much as grunts, just flip the switch, take them out of the study. So here's the results. The study was successfully completed and published. Now, they start out with 82,000 people. These are 82,000 people that were potentially touched by the anesthesia department, but you got to pull out, they excluded 62,000 of them. 20,000 simply because they weren't getting general anesthesia. 20,000 because they weren't using that monitor. So you end up, and 400 people said, I'm out of here. So 412 people had taken the assertive, I would not like to be enrolled in this study, out of a potential of, let's say 20,000 were eventually randomized, so let's say out of the 21,000 or whatever, 400 dropped. They then were allocated and the like, so and I checked again, so they're randomized rather, 10-10 more or less. Then you opt out 49-42. So you got about 50 people out of 10,000 in each group opting out, and what that meant was when they got out of the operation at some point during their recovery, they realized what they had agreed to or had heard about and said, what are you talking about? I don't want that. At least pull my data. I don't want it counted, et cetera, et cetera. So they basically said, okay, and did that. Yeah, 2 minutes? 20 minutes. Okay, so I should speed it up or shut up. So basically, it was just an example of we were able to work within the regulations. We were able to get the project through. I think we did it properly. And the PI was able to get a rather robust result, to say the least, with minimal aggravation, as he said, and certainly like. So I would argue that imagination and cooperation solve most things, even under the current regimen that's there. I would say real challenges that we have to address is such issues as randomization by hospital, region, or ward, where they just decide that we're going to try, and CMS will do this, we're going to try this new billing thing or this new this, and we're going to put it in this part of the country and not that part of the country. It's clearly research. I mean, whether or not it's federally regulated or not, we could argue forever. But there's a lot of stuff that they say, well, we don't know if it's going to work, we're going to try it. But it's randomized at such a level where IRBs aren't going to look at it and probably no one else. That we do come into these sort of discussions, I really do hope that we avoid the looking into people's hearts, which literally was part of the QA thing. Oh, do you plan on, oh no, I'm never going to write this up. I don't plan on generalizing. You literally were supposed to, when we first began doing this, is what's their intention, what's their motivation? And as a psychiatrist, I can say, yeah, I'm gonna get that right. And then lastly, and then I would say the big thing that doesn't get addressed is how does the IRB or even society address, you design a study where the two arms are comparable and it's for minimal risk, but it's achieving a goal that in and of itself we should be somewhat reflective of. So for example, we dumped in EMRs everywhere in this country. We paid a fortune for them, and one could argue they really haven't yet proven their worth in either safety, probably in billing and efficiency, but certainly not in safety. And one would argue it's made things worse, or at least half of the physicians, when polled, would argue that they believe that medical care has not been improved by it. Don't know if it's true or not, never been tested. Or, for example, this is right from the headline, robotic cancer surgeries associated worse outcomes. So if you gave me a randomized trial between two forms of robotic surgery, without having established robotic surgery actually is effective, I've now approved the study of minimal risk, except it's more than minimal risk because we've ignored the fact that the endpoint was never proven. Decreases in readmission rate now have been shown to possibly be associated with increased mortality. Yet we have certainly allowed process things that try to stop readmissions. And we've accepted that and don't study it and prove it. I mean, I ran the psych ERs where I started. 5,000 visits a year out in Queens. And I was always being yelled at for returns to the emergency room, was a metric. And we were always fighting. I said, what are you talking about? If no one comes back to the ER, it means I did a crappy job. It means I kept many more people in that should have been allowed to leave. I said, in a case, maybe it'll work, maybe it won't. I don't think he's going to hurt himself. He could get hooked up. All right, give him a chance. Didn't work, he comes back. Big deal. Or I could just keep everyone in. I could achieve the result that was asked for. That was probably unethical to begin with because they weren't trying to stop readmissions because it was bad for people, it was because it was costly. And then lastly, the whole Press Ganey thing with patient satisfaction, where people will remodel their offices and do everything. My mother was a classic. You should have seen the suit the doctor was wearing. Gorgeous. Oh, and the furniture and the woman at the front desk, absolutely wonderful. Great, and a good location, and the doorman helped me in, it was great. Yeah, Ma, anything about care, anything about this or that? Oh, I don't know, he seemed as good as the next guy, but I'm gonna give him good ratings. The point being is that, in fact, it's not particularly correlated whether or not you received proper care, much less if it improved your outcome. But people will spend a lot of time and effort going after that. In fact, it may even be detrimental. So, in summary, And that's it. So thank you very much.
I'm going to maybe then start. Dr. Magnus, towards the end of your talk, you suggested that understanding this new dynamic in the healthcare system where it's not a relationship between doctor and patient, it's a much broader set of relationships. If we reconsider the ethics of the clinical environment, it can help point us in the direction for the regulatory. I sometimes think some of the stuff that's in clinical ethics today comes originally from the regulatory or the research side. So this seems an inversion. Do you have thoughts about that?
It's always hard to say if they kind of go back and forth, right? So when you think about informed consent, Nuremberg was before Salgo v. Stanford, but Moore was before Nuremberg. So, I mean, some more v. Williams. So they kind of go back and forth. But ultimately, I think they're both derived, though, from at a very fundamental level from our picture about what medicine and medical research is. So you go back to Helsinki, you go back to the Belmont Report. When you go back and read it, the notion of what a physician's relationship is with a patient plays a big role in the way in which the regulations are formulated and thought about. And so, so I think that picture, which makes sense historically at the time, I think is still behind both a lot of our clinical ethics and a lot of our research ethics. And in fact, the fact that we can disambiguate the two, which I think you're going to hear more from in a little while, it also reflects some of that. But if you think of this as a communal activity in which everybody's sort of in it together, and the decisions aren't being made by one person, and patients and participant advocates are part of the decision making about what winds up happening to you, and so you're empowered in different, much more complicated ways. If all of those sorts of things happen, then maybe you could justify thinking about things very differently. When I'm playing my role as an IRB, I have to do the same things that you have to do, which is I have to look at the existing regulations and make sure that everything's in compliance with them. So what I'm suggesting is something that would require, I think, some far-reaching revision to the way in which we think about, regulate research, and possibly the practice of medicine. However, until then that happens, which who knows how long that will take, I think it does mean that we could think about ways in which we can use the current regulations, recognizing the ways in which they're not really designed to fit the reality of today. And so, for example, that first example of the QA project, to me, the very maybe aggressive use of QA is a way of, especially since that's something that isn't regulated, fortunately. In the notice of proposed rulemaking, they did propose a regulation that to me would have been a definition that would have been disastrous. But since there is no definition, there are ways in which you, and there's already a guidance saying that intent to publish does not make something research. And so I think there's room for saying that if what you're doing is comparing existing practices and trying to find ways of improving things that we already do as opposed to trying to develop a fundamentally new kind of treatment, then you could try and be very aggressive about that label. And what we published a study, Ben and I and our colleagues, I don't know if you're going to be talking about this at all today, about the variation across IRBs. So you'll be hearing from that in a little while. So the IRBs look at the same things very differently. And so that means we could try and nudge IRBs to be more permissive in the direction that we think they ought to be, that the regulations ought to go.
So, Dr. Magnus, I loved your take-home message, which is randomized control trials are really the source of truth. And you made another point that you felt that computer science and engineering is going to be a big part of medical education in the coming years. And I'd just like to push back on that because it hasn't happened for statistics. And in much of the evidence that physicians weigh, they should have a better grounding in statistical methods to understand when a study was done properly and when it was reported properly, and it just has not happened at all.
I wouldn't say it hadn't happened at all. I mean, maybe not as much statistics as we'd like, but since that's one of the most unpopular things we make all of our medical students take, so they all do have to take a certain amount of statistics that they all have to have, and that's probably going to have to get boosted up quite significantly. But I don't know how much statistics is required from medical schools around the country. But
I mean, there were 800 statisticians who stood up, signed a letter, and said, "Listen, what you're doing now in major medical journals is incorrect. Stop using p-values because they're worthless."
Yeah, I mean, but I think those are two very different points, right? So we teach them some statistics. The fact that there's been, that the way in which people, the amount that they've learned, so that there's a focus on knowing how to calculate p-values when and when they haven't even thought about other sources of bias, and nobody knows how to get a genuine, appropriate sample to use, and all the other sources of bias. So I think that's a point well taken, but I think that's more than just learning some statistics. That requires actually, so we probably haven't gone far enough in the training of folks. But I want to come back, if you mentioned that my point about the importance of clinical trials, and I want to come back to what you said. The example you gave was great. I want more clinical trials, and I have no doubt that it's possible to do them through the regulations. But you have to have the example that you gave is one where they had to have had funding, a study coordinator, there's somebody who goes out and get consent. But that's not, we can't do that for all the kinds of things we want to do for all comparative effectiveness. That is not scalable at the level that we really need it to happen. And so that's really what those examples and that I was talking about before were trying to find ways of getting the shrink down wasn't a shrink down of individuals. It was a shrink down of physician practices because they were being forced to be recruited to be able to be the ones who are conducting the research. And right now we have a system that makes it really, really challenging and really hard to do this on a large scale. And so what we need are more trials, and the more work we do with AI, the more important it's going to be to have more trials. But if we continue to have the current regulatory approach to all of those in this kind of domain, if we don't want to use those as QI and exempt, then the process is going to be very challenging. And so I'm hoping that this becomes a way of pushing us more towards the learning health system. Aggressive use of QI might force us to think as a system about what we want to tell all of our patients and participants, or else we're going to be stuck with really biased outcomes in which we're doing things that are really not in the best interest of our patients.
So if I could push back a little bit there, is that I also think we're woefully inadequately using technology that does exist in terms of consenting and keeping people informed. We've approved electronic consenting of one form or another for years now, both on apps and online, as well as keep people informed of what's going on. So I think, again, there's a way of accomplishing, it may not be completely under the current regs, and I'm not going to dispute that because I'm certainly not going to defend the regs. But I do think that people should know what's going on, and I think there's ways of doing that probably within the regs. And again, if it's minimal risk, it's minimal risk. I think the problem is that we do things thinking it's minimal risk, but we haven't given it the thought necessary to see whether or not it really is. And I'm certainly not suggesting that, that you or your IRB is like that. But I mean, clearly we see it. So I don't disagree at all with the premise.
Thank you. I want to ask a follow-up question on the question that was just asked. So, Dr. Magnus, you mentioned that this ethos of medicine, and I think you're absolutely right about that we often conceptualize that as a relationship between doctor and patients. Well, actually, it's a whole team. What surprises me is that in your talk, you I think, assume that the role of the physician will be the same, or at least that the central position of physicians and medical doctors in our system will be the same. And I think in follow-up to that point that was just made, it might well be that medical schools are so slow in adopting these processes that we end up in a system in which there is a team of, say, various kinds of registered nurses, supported by algorithms, and medical doctors far away on call. And then medical doctors might just have missed the point. You see what I mean?
Yeah. No, I tried as much as possible to use the word clinician rather than physician in some of the things that I was saying, because it's not just going to be physicians. It's about nurses, nurse practitioners, any advanced practice practitioners. So, so it could be lots of people. I think it's hard to know. I think there's, in the end, what winds up happening in the clinical setting is partly us obviously determined by social factors, and I'll just say the medical community has historically been very, very good at protecting its privileges, and so I would be very, very surprised if anything really happens that will threaten that without some kind of very strong response that prevents that from happening. That being said, I mean, I think many physicians, and we heard that earlier today, would welcome the chance to have like certain things offloaded so that they can, and we've already seen some of that sort of distribution happening. But again, that even highlights even more why it's a team. It's not just a team of physicians. It's as I said, it's with a system, and the teams include physicians and social workers and nurses and NPs and PAs and all these different pharmacists. And so, yeah, all of these clinicians are all involved in care, and I think so it isn't just about physicians. That being said, so the point that I made about the importance of the black box, ultimately so at least in the inpatient setting, which is where I do most of my work, in the inpatient setting, ultimately the decision making comes down to the person who's ultimately responsible for what happens to the patient, even if it's a whole team that's involved, is the attending physician. And that relationship and the importance of the attending physician and their responsibility means that person, they're the ones who has to, the buck sort of stops with one person. And even if the decisions are constrained in all kinds of different ways by a system, it's going to be important for that person to understand all of those things and on those pieces. And that's why I think we need to change medical education, because whoever's going to be the attending is still going to have that responsibility. And I don't see the attending, even though it's somewhat of a holdover, the notion of an attending, of that sort of dyadic relationship, I still think that core part of it is going to be, that at least I think is going to be with us for a long time.
All right, so that's all the time we have for this session, but there is a full panel discussion at the end, so perhaps people with more questions will get them in then. Thank you very much to Dr. Magnus and Dr. Martin.